Now for session 5, I am inviting Dr. Sudhakar Singh for chairing the session. Dr. Nilesh. Dr. Nilesh is here. Dr. Krishnaji Pandey. Dr. Kshitish Tiwari is here. And Dr. VP Singh, sir. Sir, please. I think Dr. Dharmen Jain, sir, is here. Dr. Ravi Vishnu.
In this session, we are going to talk the OMT versus the revascularization in the coronary heart disease by Ravi Vishnu. He is the professor and head of department ISGIMS Patna.
Good afternoon, chairpersons, faculties, delegates. First of all, I would thank Dr. Alok Singh for inviting me in this conference for a talk. The topic given is one of the most frequent debated topics in the cardiovascular medicine. What is the choice between medical therapy versus the revascularization for the management of chronic coronary syndrome patients? As you all know, the chronic coronary syndrome is a new term which was replaced by ESC in 2019 for the stable ischemic heart disease, and it is the one of the most common manifestation of ischemic heart disease, affecting half of the coronary artery disease patients. The CCS is a dynamic and a progressive disease, and it is not a static condition. Now coming to the pathogenesis of ACS, as you all know, the ACS is due to the plaque rupture or the plaque erosion, which leads to either the subtotal or total occlusion of the artery, leading to the myocardial ischemia and the necrosis. But the pathogenesis of CCS is complex. It is not always the atherosclerosis, but also it is at the level of the macrovascular and the functional level. There is an endothelial dysfunction. It may be in the form of epicardial vasospasm or the impaired vasodilation. So, there are two theories that that are present in the pathophysiological status of the CCS: the epicardial stenosis centric model and the biology centric model. Epicardial stenosis model means that when there is an obstruction, you open with the revascularization. Biological centric model involves the biochemical, atherothrombotic and the inflammatory markers, and it approaches the conservative management. So these are the two complementary natures, but they are highly competitive in each other. Now coming to the therapeutic objective in the CCS patients, the treatment should be individualized in every patient, and our goal should be to reduce the symptoms and the limitations of the patients, and we lower the risk of major adverse cardiovascular events, promote the lifestyle and the risk factor modification, and prevent the disease progression, and in the last improve the survival and the long-term outcomes. So I will discuss the lifestyle management, pharmacotherapy and the revascularization in detail. The lifestyle modification is the class 1 indication in all the guidelines. It comprises the exercise, aerobic exercise, Mediterranean diets or the DASH diet, no smoking, weight management and the cardiac rehabilitation. Now the optimal medical therapy is the cornerstone in the management of CCS patients, and the studies have shown that it effectively stabilizes the atherosclerotic plaque and significantly reduces the MACE events and which leads to the delay in the disease progression, prevent the acute coronary syndrome, and improve the prognosis. And what are the core components of the OMT? This is the anti-anginal to reduce the ischemia, antiplatelets, lipid management, ACE inhibitors, ARB inhibitors, SGLT2 inhibitors, the GLP-1 receptor agonists, and also in the recent guidelines, the anti-inflammatory drugs like the colchicine has been used. Now coming to the anti-anginal drugs, they should be used as a single therapy or in the combination therapy. These are the various possible combinations shown in the for the anti-anginal drugs. Also, the aspirin should be the given in the every patient, and it should be combined with the P2Y12 inhibitor. Once the patient goes for the PCI, always assess the ischemic risk versus the bleeding risk, and these are the guidelines when we have to give the dual antiplatelet for the 6 months or the 12 months, depending upon the ischemic and the bleeding risks. Lipid lowering drug, aggressive lipid control should be used in every patient, and also when the patient goes for the post revascularization, and also there are new molecules are available. The ezetimibe has been added to the statin when the LDL levels are not below the 55, less than 55 millimoles per liter. Also there is a role of bempedoic acid, and also when the LDL level is not decreases, then the PCSK9 inhibitors further reduce the CV events. Blood pressure should be tightly controlled. Also, the neurohormonal drugs like ACE inhibitors or ARB and ARNI are used for the remodeling and the prognosis. And now, the CV protective anti-diabetics drugs are also available. That even beyond that, when the diabetes are not done, when the SGLT2 inhibitors, the GLP-1A, RA inhibitors are the class 1 indications. Now this is class 2 indication is the anti-inflammatory drug which is in the proved in the Lodoco 2 trial. The colchicine 0.5 milligram should be considered to reduce the myocardial infarction, stroke, and need for the revascularization. And this is the post hoc analysis from the Syntax trial which have shown that if you follow for the 5 years, the OMT has significantly reduced the risk of death or the composite of endpoints of death MI, CVA throughout the 5 years of follow-up. And we have also the evidence favoring the OMT from the Courage, Bari 2D trial, Ischemia trial and Orbiter trial that favors the OMT. But there are certain limitations of the OMT, and what are they? 20 to 30% of the patients have persistent angina or recurrent ischemia, and they have the non-adherence and therapeutic inertias lead to the poor outcomes, and they have limited relief when the patient is having extensive ischemia like left main and the 3 vascular disease. And even after the LDL is reduced to 55 or they are on the OMT, the residual event is still there. So coming to the revascularization, it is always a topic of debate as there is no strong evidence that support the effect of revascularization on the all-cause mortality. Revascularization means in the cases means either you open the artery by the CABG or the PCI, and both CABG and PCI restore the coronary perfusion, relieve the ischemia and improve the myocardial oxygen delivery to the symptomatic patient despite OMT, but they do not heal the atherosclerosis. So what are the criteria when you need the revascularization? Indicated when the patient is having angina despite the maximal OMT, and it is recommended in the when the patient is having left main, proximal LAD or the 3 vessel disease with LV dysfunction, multivessel disease, severe stenosis in the proximal part, large ischemic burden, more than 10% of the LV mass, or when the FFR is less than 0.80. So we should organize with the heart team decision to integrate the anatomy, viability and the comorbid condition, and most important thing that the OMT should be continued alongside with this intervention. These are the various trials which are between the revascularization versus OMT from Courage trial to the recent guideline from the ESC in 2004 to 2024. Now these are the landmark trials in the chronic coronary syndrome. The Courage trial, Ischemia, Bari 2D, Orbiter 2, stitches and the revived BCIS2, and there were no reduction in the MACE with the routine cardiovascular revascularization, and they have come with the controversial outcomes. Now coming to the COURAGE trial, which was published in the 2007 and first time defined the what is the OMT. Around 2000 patients were taken and the PCI plus OMT was compared with the OMT, and the death and MI between the two groups were non-significant at the 4.6 years follow-up and even after the 15 years follow-up. And PCI shows the faster angina relief but no survival benefit. So OMT was validated as the first line therapy in stable ischemia from the COURAGE trial. Although there were very drawbacks from the study, the BMS was used, and these were the just the some drawbacks from the COURAGE trial, but it has established the OMT as the first line drug, first line therapy. Coming to the BARI 2D trial, which was published in 2009, in which the diabetes plus stable angina patients were taken and revascularization either in the PCI plus CABG plus OMT was compared with the OMT, but the strategy of revascularization failed to demonstrate the superiority, and the 5-year mortality was similar and no survival benefit was noted in these two groups. And although the CABG reduced the MI, but CABG has shown the extensive reduction benefit in the extensive CAD and the diabetes. Now coming to the ischemia trial, this was the major trial, and the hypothesis was that in this trial, the patient is a stable CAD and with moderate to severe ischemia were taken, in which it was thought that invasive therapy might be beneficial, and they have enrolled the high risk patient and they randomized the patients prior to the diagnostic angiography, and they given the at par the OMT because this was a recent trial in 2020, while COURAGE it was in the 2007, and they employ the state of art PCI in all the patients. But the result was that the primary endpoint in the form of CV death, MI and hospitalization was not significant, and there was no mortality benefit, and there was better symptom relief with the invasive therapy, and in the invasive strategy there was increased incidence of peri-procedural MI, while in this conservative therapy there was a high risk of spontaneous MI. So the benefit was shown in the 3 vessel disease, LV dysfunction and high ischemic burden subsets. Orbiter 2 trial was when the patient with the PCI with stable angina was compared with the SAM procedure, and the PCI resulted in the lower angina symptom score than a SAM procedure. This was the revived BCIS study in which ischemic 700 patients were taken. From the patient subgroup where ischemic LV dysfunction, that is EF less than 35%, they were compared with the PCI plus OMT versus the OMT, but there was no difference in the death and heart failure hospitalization. Also the EF was equivalent in both the subgroups. But this was contrast with the stitch and stitches trial, which shown that the CABG at the 10 years follow-up have a better survival gain. Now coming to the meta-analysis between the OMT and the revascularization, around 20,000 patients were studied in the meta-analysis, which have shown that there is no mortality difference between the PCI plus OMT versus OMT alone. PCI reduces the spontaneous MI and angina, but there is decreased peri-procedural MI, and CABG has shown the survival benefit confined to the multi-vessel vessel diseases, left main and the diabetic subsets. And the modern analysis reconfirmed the initial OMT as a default strategy, and quality of life is initially better in the PCI, but it wanes after the 3 to 5 years. These are the guidelines from the ESC 2024. In the CSS patient, more than 35%, the revascularization is recommended once the patient is having the significant left main disease or significant 3 vessel disease, or the involving the proximal AD with a significant stenosis. Now coming to the how these trials were based on the angiographic based PCI and the functional assessment was limited. So in the real outcome, when you see that this is the stenosis is more, but if you evaluate the physiology, then the stenosis may be less. So these were the two major trials, the FAME 1, FAME 2 and FAME 3 was compared the PCI versus CABG, but the FAME 1 was published in 2009 which suggested that the two arms were there, FFR guided PCI versus angiographic guided PCI, and they showed the decreased MACE events. The FAME 2 was prematurely closed, and this which has again shown that the FFR plus PCI have shown the urgent revascularization, decrease in urgent revascularization and similar death and MI versus the OMT. So the FFR guided arm has a better survival. So in the physiological significant CAD, the revascularization improves the clinical outcome as compared to the medical therapy, and this is the class 1 indication. Now after our post courage trial, we have lot of drugs are there. Also we have improving our PCI outcomes. We are using the FFR guided PCI. The coronary CT angio is used. We are using the IVUS and the OCT for the better stent optimization. Also the DCBs, drug coated balloons are used for the to improve the PCI outcome. Now coming to the Indian data, the Indian CCS patients have the uh, younger population less than 55 years. They have a higher incidence of diabetes, hypertension prevalence, and the CREATE and Kerala registry have shown that they have underused the statins and the secondary prevention, meaning that they are underusing the OMT therapies, but the PCI's use have increased more than 150% in a decade, and OMT adherence is poor. So to summarize, the OMT remains the cornerstone therapy in the CCS patient, and the revascularization is indicated for the refractory symptoms or prognostically significant coronary artery disease who are having the high risk anatomy or the functional ischemia is there. OMT improves the outcome, and till date, no clinical trial has shown a benefit of PCI over OMT alone on the survival, and CABG really offers the mortality benefit in the left main, proximal LAD, and the 3 vessel disease with LV dysfunction, or in the multi-vessel disease with LV dysfunction. And OMT should be continued after the revascularization. So the imaging, risk stratification, and the heart team approach should be optimized for the patient selection. So OMT heals the atherosclerosis, PCI treats the lesion, and the CVG treats the artery. So lifestyle and modification and OMTs and the revascularization, they are not an individual subset, but they should be act as a group in which patient which needs the most, and the revascularization when the patient is having the documented evidence of ischemia. Thank you very much.
Thank you, Dr. Ravi Vishnu, for excellent talk of the OMT versus the revascularization. Any questions from the house?
Dr. Vishnu, I really enjoyed your talk. Dr. Sharma, you're Dr. Sharma? You're Dr. Sharma. No? Yeah, because I wanted to ask this question during your talk also. This, if the patient is on OMT and he has a coronary angiogram and OMT, and he comes to, because I'm a surgeon, so cardiologist said to get the opinion for coronary revascularization. I find the patient very stable on the OMT. But the patient says that, and cardiologist also suggested he can continue on OMT, but he has Ayushman card, and he says I wants to go for whatever, because he thinks it's free. So what will you do there? Because he does have indication, but you decided to keep the patient on OMT because he is pretty stable, chronic stable angina.
When the patient is very stable and there is no evidence of ischemia, documented ischemia, no chest pain, then there is no need. We should always advise him to continue on the OMT.
But how will you convince those patients? Because the moment they have the Ayushman card, they think now
the
they got a
Ayushman card is only giving for just giving the stunt. which is not at par with not the third generation stent we are giving in the Ayushman
That we know.
card.
That-
We are giving the second generation, or depending upon the what is the institution protocol or the tender issues
No,
are there.
it's entirely up to us to decide what the patient should be given. Because like we have already suggested OMT. I agree with the cardiologist, the OMT should be the treatment.
Basically, it should be a shared decision. It should be a shared decision approach between patient and doctor. You must explain to the patients what are the hazards of if you go for revascularization and what are the benefits of revascularization. Definitely, if a patient is stable on OMT, then definitely revascularization is not indicated in that patients until unless he has recurrent angina or angina non-responding to medical management. Just carrying a Ayushman card holder doesn't gives him a license
Ayushman
to
is
go
not
for
a entry card
revascularization.
because we have to discuss. I agree with Dr. Avdel. हमको डिस्कस करना चाहिए वो कि आपका नहीं होगा तो ये घाटे हैं, स्टंट थ्रोम्बोसिस का भी चांस है, मान लीजिए वो कैल्सिफाइड लीजन है, स्टंट ठीक से बैठा नहीं, या सीबीजी का ही वो है, कुछ अंजाइना नहीं हो रहा है, तो हम लोग डिस्कस करना चाहिए क्योंकि आयुष्मान कार्ड एक एंट्री कार्ड नहीं जिसका होना
It's
है.
a shared decision basically.
Now the situation is the patient has Ayushman card. If the patient doesn't have Ayushman card, he easily gets convinced because he says that he has to pay from his pocket. So OMT fine because
अब पेशेंट आप पे ही दबाव डालता है कि सर आप करिए, आप नहीं कर रहे तो वो है, लेकिन
yeah,
patient
we do
को-
we do tell them because-
Ultimately, you have to follow the guidelines. The Ayushman card doesn't
Discussion-
warrant you to still the guidelines.
no, but the
We are not
आयुष्मान
treating
कार्ड तो
Ayushman
हमको
card, we are
discuss
treating
करना है,
patient.
उसको कन्विंस करना है, नहीं तो उसको हम लोग वैसे भी अगर पेशेंट आता है तो मान लीजिए 70,000 मिलता है, we always give the extra 50,000
an individual
from your
decision.
pocket. So, maybe cutting balloon, maybe rota ablation you required for the stent, नहीं तो स्टंट बंद हो जाए, हम कोई भी स्टंट लगा देंगे, बंद हो जाए, आप देखिएगा.
he is still happy that कि 85 देना पड़ रहा ना.
Sanjay wants that the European
हम आपके पास ही भेज देंगे सर.
recommendation is
CBG करा
not validated in India. We require a separate comparative study along with the
ये सर ये
Ayushman
डिस्कशन
non-Ayushman
कभी
group.
खत्म नहीं होने वाला है.
Ayushman.
Dr. Vishnu, just one thing. There's a lot of talk about vulnerability of the plaque now. There is some evidence to suggest that vulnerable plaque maybe is more important. We talk about stable angina, but we have evidence to show that maybe vulnerable plaque after the prevent study.
prevent study.
So, does it hold true even for coronary syndromes, chronic coronary syndromes, or there could be a way further that studying the plaque with the new imaging modalities, that this could be one way forward?
Nowadays, it is the class 1 indication for every PCI. You should go for the imaging to detect the vulnerable plaque or calcification or anything. So vulnerable plaque is more dangerous because the plaque is stable, 70% may not cause the occlusion, but the ones of 40% with the vulnerable, all the factors of vulnerability, they may rupture or erode. So we have to do the imaging in all the cases.
more true for-
Again, this cost of this imaging have to be from the patient side, because imaging costs at least 70,000 to 1 lakh, depending on the institution.
If there is no mortality benefit and patient is happy, chronic stable angina, patient is happy. Occasionally he is getting pain, anginal pain on severe exertion. It means he is happy, he is okay. So he is not recommended for revascularization because there is no mortality benefit.
No matter what. Once the patient is having high anatomical risk or the patient is symptomatic despite the OMT, then we should go for the revascularization.
हम ही देंगे इसका. ठीक है, इनको मोमेंटो दिलवा देते हैं. Thank you, Professor Ravi Vishnu, for your nice deliberation. I will request Dr. VP Singh sir to give memento to Dr. Ravi Vishnu.